Will inform the students of the admissions. Tell them.
Sonali ma'am, is it visible?
Yes, Ankit, it's visible.
Thanks, sir.
Good morning. Today we'll be discussing about electrophysiological studies. We'll be concentrating on two modalities, that is VEP and Bera. One is visual evoked potential and the other one is brainstem evoked response audiometry. So evoked potentials, they are electrical potentials that occur in the cortex after stimulation of a sensory organ, which can be recorded through surface electrodes. So these EPs represent a non-invasive low-cost method to assess the sensory processing of information of CNS in real time. So these EP traces also consist of succession of waves and peaks, which reflect the neuronal responses to different levels of the sensory pathways. And the technique permits the assessment of the conduction times of sensory impulses in the CNS. So basically, EP studies are concentrated mainly on response times of the sensory organs, and based on these response time, we can like basically tell how well the pathway is, if the pathway is normal or it is abnormal. In general, the value of all evoked potentials, they are related to the fact that the conduction times in the peripheral nervous system are indirectly related to the indirectly they reflect the conduction of the central nervous system, and their utility parallels the usefulness of the conduction system in peripheral neural pathways. What is the utility? Why do we use the EP studies? These help in testing of the sensory function in presence of non-contributory clinical examination. Sometimes when the clinical examination is doubtful, we are not sure, then we can get a EP study. And investigating purely subjective symptoms, when the patient comes with particular set of complaints which cannot be objectively assessed, then we can go ahead and conduct an EP study and to detect whether they have an organic origin. So coming to visual evoked potential, these are electrophysiological responses recorded from the skull. The responses that we obtain are through stimulus that we provide. The stimulus can be of two types. One is a pattern stimulus, the other one is an unpatterned visual stimulus. So through these stimulus, we can assess the integrity of the visual pathway from the optic nerve to the occipital cortex. So there are many different types of visual evoked potentials. So that again depends on the type of stimulus that we give and the duration of stimulus that we give and the different patterns of stimulus that we give. So stimulation at a lower rate, they produce transient visual evoked potentials, whereas stimulation at a higher rate that persist for the duration of the stimulus, these are called as steady state visual evoked potentials. So the responses evoked by pattern stimuli are called as pattern VEPs, and responses evoked by unpatterned stimuli are called as flash VEPs. So pattern stimuli, they usually require the cooperation of the patient. They usually require a patient to fix the gaze at one particular point. Flash VEPs are used in those cases where the patient is not very cooperative, or the patient is an elderly patient who has issues with vision and issues in the visual pathway. So the choice of stimulus, again, the patterned visual stimulus elicit responses that have far less intra and inter-individual variability. So it is more accurate and has greater sensitivity. So between the two eyes also, the variability will be less, and between individuals also, the variability will be less. So among the patterned VEPs, the checkerboard pattern is the most commonly used pattern, most widely used pattern. Unpatterned stimuli, as I said, the patients who are unable to fixate or attend to a particular stimulus, in those patients we use. Chromatic patterned VEPs are used mainly in patients with color blindness. And the generator of VEPs, where exactly do these waves get generated? Those are believed to be the peristriate and the occipital cortex. So this is the machine that we use for the VEP. This is how the screen looks like. In the screen, we have a central dot. Here, there might be a red or a yellow dot on which the patient fixates his vision. And based on the like pattern responses, we obtain a visual evoked potential. So coming to the visual pathway. So as we know, visual pathway, there is a visual field. There is a temporal visual field and there is a nasal visual field. The nasal field is directed towards the temporal half of the retina, and the temporal visual field vision is directed towards the nasal half of the retina. They form the optic, they fall on the optic nerve head or the retina, through which they go to the optic nerve, from which they decussate in the optic chiasm. Decussation mainly happens with the nasal half of the retinal fibers. So the temporal half usually moves ipsilaterally. Temporal half moves ipsilaterally, and temporal half, both these nasal half of the contralateral retina and the temporal half of the ipsilateral retina, they move as an optic track towards the lateral geniculate body of the thalamus, through which optic radiations are generated. These are also called as geniculo-calcarine tract. So the temporal and the parietal optic radiations, they lead towards the occipital cortex, and in the occipital cortex, the generated visual image or the generated responses, they are collected through surface electrodes. So coming to patient instructions, we need to give certain instructions to the patient to ensure full cooperation of the patient. The patient should be explained what exactly the test that we are doing and how the test will proceed, and what are the things that we attach on the head of the patient. So also the ability to visually fixate towards a particular stimulus is very important, and patient has to be instructed to avoid hairspray or oil after the last wash. Glasses which the patient usually wears has to be put on during the test, and it is better to avoid mydriatic or myotic 12 hours prior to the test. Coming to the equipment, the electrode impedance should be below 5 kilowatt, and the low cut filters are set at 1 to 3 hertz, and the high cut filters are set at 100 to 300 hertz. This is to separate the other stimulus that can occur, because these electrodes are very sensitive. Small movements of the muzzle, the chin, can hamper the recording. Amplification ranging between 20,000 to 1 lakh is used, and the sweep duration is set at 250 to 500 milliseconds. So coming to electrode placement, standard EEG disc electrodes that we see, the rounded ones, those are used for the test. The scalp skin is prepared by degreasing and abrading the skin. Initially, we take a piece of cotton gauze and we rub over the scalp surface. This is to degrease the scalp, and little abrading is done, on which the jelly application is done and the electrode is kept. There should not be any hair around the area where we apply the electrode. And active recording electrode, that is called as OZ, that is placed posteriorly 2 to 4 centimeter above the inion. The inion is the inion is the place where there is a the highest there is a bump over there. So just 2 to 4 centimeters above the inion is where we place the recording electrode, and that is called as OZ. And the reference electrode is called as the FPZ, and it is placed 12 centimeters above the nasion. This is the nasion, and up to 12 centimeters above the nasion is where we place the reference electrode. Again, the same thing has to be done as in the scalp electrode, where we place the degreasing and abrading and placement of the electrode. The ground electrode CZ is placed at the vertex. So there are different other types that we usually use based on patient's visual acuity, and it depends on other aspects also. So this is how the electrode placement is done. 12 centimeters from the nasion is the FPZ electrode, that is the reference electrode. OZ is the recording electrode, that is placed 2 to 4 centimeters above the enion. CZ is your ground electrode. So the variations that they usually do, the FPZ is kept at the level of PZ sometimes, and OZ electrodes can sometimes be placed at L5 and R5. That is based on the visual field, particular visual field testing. If the patient has some disturbance in the visual fields, then the recording electrodes can be moved slightly laterally. This is 5 centimeters from the recording electrode. So it is named as L5 on the left, 5 centimeters from the recording electrode over R5 on the right. So International Federation of Clinical Neurophysiology, they recommend a minimum of 2 montages to be done. That is recording electrode OZ to reference electrode FPZ. That is one channel. And the second channel is OZ to the linked ear, whichever side the recording is taking place. So otherwise, 4-channel montage is usually used in patients who have visual field defects. So OZ to FPZ, CZ to FPZ, L5 to FPZ, and R5 to FPZ. So how we conduct the procedure, the room should be dark. We usually test one eye at a time. The seating distance should be 70 to 100 centimeters from the monitor. Stimulus, as I said, either pattern or unpatterned or chromatic pattern based on the visual acuity and color vision. Fixing the gaze at the centered dot in patterned, as I said. And once this is done, always check the impedance of electrode before starting the averaging process. So as I described, the same things that has been recommended by the International Federation of Clinical Neurophysiology. So stimulus rates of about 1 to 2 hertz are recommended. Normally 1 to 8 hertz stimulus are usually used. Generally about 100 epochs are averaged. In this VEP, the epochs are a little different. One epoch is usually defined as the time duration from the starting of the stimulus, 15 millisecond before the provision of a stimulus, to about 200 milliseconds after the formation of the wave. So that's about 250 milliseconds constitute one epoch. So sometimes 250 to 500 epochs are required to obtain a clear potential in some cases. So pattern that extends equally to both sides of the fixation point are called as full visual field stimulus in one eye. So pattern that extends equally to both sides of a single fixation point is called as full field visual stimulus. Pattern presented to one side of the fixation point is called as a half field stimulus. And as I said, in cases of visual field defect, if there is a small sector of visual field that is being presented with the visual stimulus, it is called as a partial field visual stimulus. So for judging of the reproducibility of the waveforms, there should be at least 2 waveforms that should be averaged and superimposed on each other to form an average waveform. If asymmetrical activation of visual cortex is found, as I said, additional electrodes are placed on L5 and R5, and those channels are used for testing. So this is how the basic testing goes. There will be a checkerboard pattern. There will be a red dot for fixation. The electrodes here, they have used a band type of electrodes. Normally we use the disc type of standard electrodes, and one eye is usually covered. So based on the number of sweeps and the number of stimulus those are given, the visual potentials are recorded, and those are averaged to form one particular potential. So coming to negative and positive polarities in the pattern, once we obtain the pattern of VEPs, the negative polarity is depicted as N, and those are usually, they form the positive wave, and the positive polarity, they form the negative deflection. Those are designated and as N and P respectively. Peak latencies are expressed in milliseconds. So about 100 to 150 milliseconds is where we get the P100 latencies. So these are standard latencies that usually occur at these timings, that is N75. So negative wave initially comes at the 75th millisecond. P100 positive deflection comes at the 100th millisecond, and N145. So these are the standard waveforms that can be obtained. So from the occiput, while wave N100 is those are recorded from the mid-frontal region as it goes towards the occiput. So N100 is recorded from the mid-frontal region. Peak N145 is highly variable, and those are not usually used for standard interpretations. So this is how it normally looks like, the VEP. The initial negative deflection. This here, if you see one standard box here, it is about 50 milliseconds. So the N75 that occurs in the second box, somewhere in the middle. So that is why it is called as N75. So P100 usually occurs at the end of the second box or at the start of the third box. And this N145 is occurring at the end of the third box. So how do we analyze this VEP? So we identify the waves, then they determine the absolute peak latencies and the amplitude of the waves, and then determine the interocular latency difference. Coming to normative data, P wave latency is somewhere around 102 plus or minus 5 seconds. So 97 milliseconds to 107 milliseconds is the standard deviation for P wave P100 latencies. And RL latency difference is around 1.3 to plus or minus 2 seconds. That is the right eye latency versus the left eye latency. That might differ by around 0.7 to around 3.3. So if P wave of the right eye is somewhere around 102 milliseconds, the P wave latency of the left eye might be somewhere around 101.6 to 105 milliseconds. So that is the standard difference between the two eyes. Coming to the amplitude of the wave is the total depth of the wave that we obtain. So that is around 10 plus or minus 4.2 microvolts. That is 5.8 microvolts to around 14 microvolts. So each eye projects to bilateral optic cortex. As I described, the nasal half of one eye goes to the contralateral half of the occipital cortex. Temporal always go towards the ipsilateral. So unilateral VEP abnormality, that means the lesion is usually prechiasmal because that is where the decussation takes place. So that is why there is only one eye abnormal. Bilateral visual abnormalities, usually localizing value is a little difficult to exactly localize. But in unilateral VEP abnormalities, we can confidently say that it is usually prechiasmal because the decussation has not yet taken place. So what are the abnormalities that we see? Abnormalities include either latency prolongation, amplitude reduction, or combined abnormalities of latency and amplitude. So interpretation, P100 latency more than 3 standard deviation or interocular latency difference of more than 10 millisecond is significant. As I described, it is around 3 to 4 millisecond difference between the two eyes. But if it is more than 10 millisecond, it becomes significant. And also the described P wave standard deviation, 97 milliseconds to 107 milliseconds. More than 3 standard deviations of that recording, if it is present, then it is abnormal. Latency again depends on fast conducting fibers, and prolonged P100 latencies are seen in demyelinating lesions and in some cases of retinopathy and glaucoma. Amplitude reduction, again interocular amplitude ratio is used. Amplitude ratio of one eye is compared with the amplitude ratio of the other eye. So left eye by right eye or right eye by left eye. So if it is more than 2, then the eye with reduced amplitude has an axonal lesion. Here, latency prolongation indicates demyelination or retinal lesions. Amplitude reduction indicates axonal lesion. So how do we calculate the amplitude reduction? We compare between the two eyes. If the ratio is more than 2, that indicates there is some abnormality in the eye with the reduced amplitudes. Combined latency and amplitude problems can sometimes be seen mainly in optic nerve compression that can produce segmental demyelination and axonal loss. In some cases, we also see bifid P wave complexes in which 2 P wave peaks are obtained within 50 to 100 milliseconds of each other. This is rarely seen in normal individuals, but sometimes in field defects, this we can see. Coming to the entity called as flash VEP testing, I told you these are unpatterned VEP testings that we do. So these are restricted to patients who are unable to visually fixate. In elderly patients with defects with refraction or opacity in the ocular media, or in young infants and uncooperative children, we usually use patterned VEPs, unpatterned VEPs. These are called as flash VEPs. So results should demonstrate reproducible peak positive responses to flash stimulation. So as we give multiple sweeps of the visual impulses, it should always be reproducible. It must be the same tracings that we usually obtain. So unpatterned brief flashes with no discernible counter are usually shown to the patient. LED board or LED goggles that are placed directly over the eyes also can be used. These LED goggles are usually better in cases of flash VEPs because they offer a large field for fixation closer to the eye, and there is minimum gaze deviation with the flashes. So coming to the factors that can affect the VEP, age is one factor that can affect VEP. Mainly after fifth decade, there is a P100 prolongation of about 2.5 milliseconds per decade. So if the patient is around 70 years and the P100 latency is obtained around 113 milliseconds, it is not prolonged because according to the standard deviation curve, up to 107 milliseconds is acceptable. And in cases of age, after each decade, we have to add 2.5 milliseconds. So at 70 years of age, around 5 to 6 milliseconds is what is the accepted extra P100 prolongation that we accept. So infant and young children, P100 latency on large checks, that is on the checkboards when we show larger patterns, then that reaches the adult value by 20 weeks. But on smaller checkboard, it takes around 5 to 6 years to reach the adult value. Gender also, there is some comparable difference. That is, P100 latency is prolonged in adult males compared to adult females. One is the larger head size in males that can influence the prolongation of latencies, and lower body temperature also can affect the P100 latencies. Along with this, some hormonal differences also can affect is what they are suggesting. And eye dominance, so P100 obtained in the dominant eye is usually shorter latencies and amplitude is greater when compared to the non-dominant eye, and that has been attributed to the neuroanatomic asymmetries of the striate cortex. So eye movements also, as I said, the importance is to get the visual fixation. So eye movements can reduce the amplitudes, but latencies are usually unaffected. So a patient with nystagmus having normal visual pathway can have reduced amplitudes, but P100 latencies will always be preserved. And drugs, as I said, myotics can reduce the P100 latencies because the light is falling on a smaller field of the retina. Mydriatics have the opposite effect because larger field of the retina are getting the visual impulses. Sedation and anesthesia can abolish VEPs. So coming to abnormalities in VEP, talking about monocular abnormalities, lesions anterior to optic chiasma can cause this abnormal VEPs. Demyelination is the most common cause. MS and optic neuritis, NMO, all these can cause abnormal monocular VEPs. Other possibilities are retinal disease, glaucoma. In some cases, early compression of the optic nerve also can cause monocular abnormal full field VEPs. Coming to bilateral abnormal full field VEPs, these are usually behind in the optic chiasm. So bilateral retinal degeneration, butterfly gliomas of the corpus callosum can sometimes cause bilateral abnormal full field VEPs. So as I described, partial field VEPs sometimes are useful for checking retrochiasmatic lesions with isolated field defects, but these are not usually routinely performed. So coming to clinical applications, these can be used to detect but not differentiate between different types. To detect all this, so multiple sclerosis, obviously P100 latencies are prolonged. VEP can contribute in finding a subclinical demyelinating plaque in the visual pathway, and as such, VEP is the most sensitive investigation, more than MRI, for finding visual field, the subclinical demyelinating lesions within the optic nerve pathway, not the MRI. So optic neuritis, again P100 prolongation is seen with or without amplitude loss. NMO, bilateral unrecordable P100 latencies and reduced amplitudes are more commonly seen. In one of the tests that was done in NMO, patients, about 47.4% of the patients had bilateral P100 unrecordable latencies. And ischemic optic neuropathy, again attenuation of amplitude is seen. It is seen earlier than latency prolongation. B12 deficiencies again can be seen bilateral, prolonged P100 latencies, and these are usually asymmetric. HIV infections initially seen as prolonged P100 latencies, then followed by decreased amplitudes. Toxic neuropathies, decreased amplitudes more than prolonged latencies. Drugs, again prolonged P100 latencies. In papilledema, usually no effect on VEP is seen, but in chronic papilledemas, again sometimes degeneration of the retinal fibers can cause mild prolongation of P100 latencies. Hereditary, again reduction in amplitudes, no effect on latencies. In degenerative diseases like Parkinson's, in late stage, prolongation of P100 latencies are seen. Compressive neuropathies, as I described, decreased amplitude with minimal prolongation of latencies, with distortion of the waveform is also seen. Cortical blindness, usually VEPs are preserved, but if absent VEP responses are there, that indicates poor prognosis. And this is mainly one feature where we can use is in malingering, where VPs remain normal, but even then deliberate suppression can be done, but this can be avoided by using larger field so that visual acuity can be adjusted, larger checkboards and binocular stimulation. So that completes VEP, basically visual evoked potential. So mainly visual evoked potential is used for detecting lesions prechiasmally. Monocular lesions. Binocular might not have that much localizing value, but binocular abnormalities indicate some specific pathologies, as I described, metabolic, some neoplastic, bilateral gliomas. These can sometimes be detected. And VEP is the most sensitive clinical test. VEP is the most sensitive modality in cases of lesions to be detected in the optic nerve prechiasmally. So coming to brainstem evoked response audiometry. So Bera is recorded from the ear and vertex. So this is in response to brief auditory stimulation to assess the conduction of the auditory pathway. How VEP is done for the visual pathway, the same way Bera is done. So Bera composed of 5 waves within 10 milliseconds of the stimulus. So once the stimulus is given, 5 waves usually occur within 10 milliseconds of the stimulus provided. Clinical utility has been established in assessment of hearing and assessment of hearing and uncooperative and very young patients to assess for hearing deficits, to assess for basically whether the auditory pathway is intact or not. With repetitive auditory stimulus, reproducible electrical potentials can be elicited and recorded by scalp electrodes. The same as in VEP, multiple stimulus, multiple reproducible potentials, and they have to be similar to each other. And these waves are generated by specific brain region and occur at predictable interval. And this is clinically useful to evaluate the integrity of the auditory pathway. So basically, once we hear the sound, it goes and disturbs the hair cells of the cochlea, pressure differences. So the pressure differences again is transmitted through the spiral ganglion towards the auditory nerve. From the auditory nerve, it reaches the brainstem. In the brainstem, we have the dorsal and the ventral nuclei. From the nuclei, they ascend upwards. Here, again, decussation happens. So bilateral pathways have bilateral representation in the cortex. So from one ear, if the stimulus is sent, it is always represented bilaterally. So it ascends upwards through the lateral lemniscus towards the medial geniculate body. From the medial geniculate body, it ascends upwards towards the Heschel's gyrus. So this is how the auditory pathway is. And in this auditory pathway, stimulus provided, we get these auditory potentials in the form of waves. So these waves are produced at particular points. What are those points? We will study further. So again, the equipment, needle and surface electrodes can be used, but surface electrodes are more commonly used because they are non-invasive. So Bera recording is done from ipsilateral ear to the vertex. Two channels are recorded from the ipsilateral ear and the contralateral ear. So both are recorded simultaneously. And so these are called as AI for the ipsilateral ear and the AC for the contralateral ear. And the reference electrode again is referred to as CZ. So channel 1 here is from ipsilateral ear to the reference electrode, and channel 2 here is the contralateral ear to the reference electrode. So in cases of young infants, because of lot of disturbances, we also use a ground electrode, that is FZ. So this is how the electrode placement is done. So this is the recording electrode CZ. The ipsilateral ear, that is called as AI. The contralateral ear is called as AC, and the grounding electrode used in infants. So this is how it looks like in a normal person. So again, electrode impedance is below 5 kilovolt, low cut filter set at 100 hertz. We can recall in VEP it was around 1 to 3 hertz, and high cut filter here is at 3000 hertz. In VEP it was 300 hertz. So amplification also differs. Here it is set at 2 lakh to 5 lakh, whereas in VEP it was 20,000 to 1 lakh. So stimulation, again, Beras are produced by brief click stimulus, which is usually a square wave pulse of 0.1 millisecond duration. So clicks are presented about 10 to 70 times per second, and at faster rates, data can be collected quickly, but the waveforms are not correctly defined. So a click rate of around 11 to 31 hertz is most commonly used, and non-stimulated ear should be masked. So if you are stimulating here, this ear should be masked, though the responses are recorded through this ear towards the contralateral ear. So here the epoch is different. Here the epoch is about 10 milliseconds, and that is generally averaged in Bera studies. In VEP, as I described, the epoch time is 15 milliseconds prior to the stimulus to 200 to 230 milliseconds after the stimulus. So however, for neonates and premature infants, 20 millisecond analysis time is preferred instead of 10 milliseconds. At least 2000 trials are averaged to get a good quality recording. However, a large number of trials need to be averaged if recording is noisy. So 2 to 3 repetitions are done together and they are superimposed to check for reproducibility. And in general, Bera repetition should impose almost exactly. It has to be the same recording each time you repeat. So the latency values should agree with each other within 0.1 millisecond. So if an epoch is 10 millisecond, the latency value should be so close that the difference of only 0.1 millisecond is permissible. More than that, you will have to repeat the study. The amplitude value should agree with each other within 10%. So more than 10% of amplitude increase is also considered as substandard study, and the study should be repeated. Normally, it consists of 5 to 8 vertex positive peaks, which are labeled using Roman numericals. The initial 5 peaks are of clinical interest. The succeeding 6 to 8 peaks are not are variable and are not clinically useful. So this is how the peaks looks like. So these 5 peaks, they usually occur at a very short duration of time. Usually within 4.5 to 5 milliseconds is the period in which it occurs. So up to 10 milliseconds is what they consider, but the standard deviation is within the 4.5 millisecond period. So what are those waves? We will see. So wave 1 is a prominent upgoing peak in the ipsilateral ear. So it appears 1.4 millisecond after stimulus and is markedly attenuated or absent in the contralateral recording channel. So once we stimulate here we get the ipsilateral wave 1, but in the other ear we will not get the ipsilateral contralateral wave 1. So patients with CNS problems preserved wave 1 since it originates from the auditory nerve. So wave 1 comes from the auditory nerve. So patients with CNS problem, they do not have wave 2 to 5, but they will always have preserved wave 1. So patients with sensory neural hearing impairment, they might have absent wave 1, but preserved wave 2 to 5. So wave 2 is poorly defined. It is a small peak that is seen along the downgoing wave 1. As the wave goes down, there might be a small peak, or as it climbs, the wave 3 climbs up, there might be a small peak. So that is wave 2. So that is prominently seen in contralateral channel recording, but prolonged latency compared to the ipsilateral. So as the signal reaches from the ipsilateral towards the contralateral ear, the time duration increases and the latency is also slightly prolonged. So this arises from two loci, that is the distal auditory nerve or the brainstem cochlear nucleus. As I said, so initial recording is from the proximal auditory nerve. Then the wave 2 is from the distal auditory nerve or in the cochlear nucleus where it joins to the cochlear nucleus. Sorry. So the earliest component it is the earliest component affected in pontomedullary infarct, which involve the cochlear nucleus. So mainly in Bera, there are three waves that are of importance and prominent. That is the wave 1, wave 3, and wave 5. We'll keep that in mind. We'll see what the importance is further. So wave 3 is usually present in both recording channels and is substantially smaller in contralateral recording. As usual, wave 3 is more prominent in the ipsilateral ear. As the stimulus progresses towards the contralateral ear, it becomes smaller and arises from the caudal pontine tegmentum in the superior olivary complexes. So here we can see this is the wave 3 here in the ipsilateral ear, AI. Okay, but the same area, wave 3 is attenuated in the contralateral ear. So wave 3 is of lesser peak in the contralateral than in the ipsilateral ear. Coming to waves 4 and 5, they are often fused into wave 4 and 5 complex. They are the most prominent component in the Bera waveform, and the morphology of waves show inter-individual and inter-auditory variation. So each wave 4 and 5 is different within the person and also between two individuals. So between the 2 ears also there is a difference. Between two individuals also there is a difference. So this is how the morphological variation we usually see. In 1 year, there might be just wave 5 complex. In 1 year, there might be wave 4 and 5 complex superimposed together. So things like this, there are multiple variations in these waves. So coming to wave 4, it reflects predominant activity in the auditory fibers, ascending auditory fibers from within the dorsal and the rostral pons. So it basically, those are the climbing fibers towards the medial geniculate body. So these are affected by tumors and cerebrovascular accident in the mid pons or rostral pons. Coming to wave 5, this arises from the level of the brain stem, either from the inferior colliculus itself or from the rostral portion of the lateral lemniscus as they terminate in the inferior colliculus. So wave 4 arises from the mid pons region to the rostral pons region. Wave 5 arises from the mesencephalon as it goes towards the lateral lemniscus. So this is how the waveforms are. So wave 1 is generated by the 7th nerve, wave 2 by the cochlear nucleus or the distal auditory nerve, wave 3 is by the superior olivary nucleus, wave 4 is by the lateral lemniscus, and wave 5 is the inferior colliculus. Easy mnemonic to remember it is E. coli, external 8th nerve, cochlear nucleus, auditory complex, olivary complex, lateral lemniscus, and inferior colliculus. So again the same. Coming to parameters of the Bera, one is the absolute latency, amplitude of different waveforms, wave 5 to wave 1 amplitude ratio, and interpeak latencies. These things we will discuss now. So interpeak latencies, the commonest interpeak latencies used in clinical practice are wave 1 to 5, wave 1 to 3, and wave 3 to 5. As I said, there are three prominent peaks in Bera response. So wave 1, wave 3, and wave 5. So between these, the latency, the time duration required to achieve each wave is calculated. So wave 1 to 5 interpeak latencies, that is from proximal 8th nerve to midbrain. So this is the measure of conduction of the time taken from the stimulus reaching the 8th nerve to the stimulus reaching the midbrain. So upper limit is about 4.5 milliseconds. So as I said, the waves complete at around 4.5 millisecond period only. And right to left asymmetry does not usually exceed 0.5 milliseconds. And it is prolonged in focal demyelination, ischemia, tumors, and so on. 1 to 3 interpeak latency measure conduction from 8th nerve towards the core of the lower pons. So upper limit is 2.5 milliseconds. Right to left asymmetry usually does not exceed 0.5 milliseconds and prolonged in CP angle tumor and brainstem infarction, mainly of the lower pons, meningitis, and SAH. Coming to 3 to 5 interpeak latencies, upper limit is 2.4 milliseconds. Again, asymmetry is 0.5 milliseconds. Isolated abnormality is not very significant unless associated with prolonged 1 to 5 peak latency variation. Coming to wave 5 to wave 1 amplitude ratio. So wave